Good afternoon, good midday, good morning. Welcome, everyone. We're very excited today for this special edition webinar. Chanel, let's look at the agenda. We are welcoming you right now. We're going to look at our latest data. Thank you for those of you who submitted data over the summer. We also have a spotlight on two of our teams. They're going to do presentations about sustaining and spreading the work, and they include UNC Hematology and Stanford Cardiology. We'll also have a few updates, and then if there's time, we'll have a review of lessons learned and muddy points. Our next slide is going to show our objectives, which are to describe strategies to sustain and spread the support of emotional health, to celebrate the success of your work, and to clarify any questions. We mentioned updates, and our next slide is one that's familiar and yet updated. Thank you, Alani. This is one of our updates, and that's that we've updated the roadmap pathway to be easier to read. And we're excited that that's on our website, and we'll share more later. We're going to look at data now. And again, as I said, we're going to see what's been happening over the summer. We look at our next slide. It will show where we are with our roadmap readiness checklist. We've had a few additional readiness assessments submitted for June, October, and February. Oh, and April as well. And then 2 people submitted a July assessment. So thank you all for that. If you look at our assessments, they've by and large increased over the quarters that we've been collecting the results. For some of them, however, you've learned more, and so you are assessing yourself a little lower. And also, the further we get to the right side of these bar charts, the lower our denominator is, which also affects our results. But fantastic job improving your readiness to support emotional health. Our next slide looks at our process measure for assessing emotional health. This slide includes both discussion and screening. Any teams that have 3 months or fewer of data submission are not included in this analysis. I mentioned this before, but the denominators of the encounters are in the table that is below the graph, and the denominators for the teams are along the x-axis of the run chart. And just to remind you, our goal is in the green dotted line. Our midline is orange, our center line, and we're at 61%. And then our range is from 0 to 100%. And I do, again, want to recognize the 5 to 6 teams who entered summer data. A huge thank you to all of you for learning and improving together. Then we're going to look at discussion on its own. And this excludes screening. As a reminder, roadmap does center the assessment of emotional health on discussion. And we have a center line of 55% for discussion. So exciting. Again, the same rules apply, that you have denominators for all encounters in the table, and denominators for the number of teams along the x-axis. Then when we look at just screening, because so many of you are working on screening, and UNC will talk some about that today, we want to give you credit and recognition for all the work you've done to start your screening programs. So again, you can see that we have the August submission where there were 5 teams, about 38% of the encounters used to screen. Yeah, thank you, Carol. I'm just going to read that comment. Oh yeah, and address Alana's question. So the run chart rules allow 1 to increase once there are 8 points above the center line. Currently, we have 7 points above the center line, so we're close to increasing or shifting, as we say. Did you do a sub-analysis of the teams that did send in data for the last 3 months and this summer? Were they always high performers? We did a sub-analysis of the early adopters in the chest tube project, and it was informative. That's a great question, Alana. Actually, what we did, and it's a great suggestion too, because we have done a sub-analysis of 3 rational subgroups, and we're not sharing that today, but they are looking at teams that started entering data in the first quarter, those that started entering in the second quarter, and those who started entering in the third quarter. And as you might expect, those who started in the first quarter were able to increase the percentage of patients whose emotional health was assessed. So that's what we'd expect. But I like the idea of actually looking at the teams who also submitted in the summer. I can say, because there were so few, that several of those teams, at least 2 of them, really did not begin to submit data until like the fourth quarter. So, but it would be interesting to look at that. Then our final graph looks at the discussion of results. And of course, this is part of the so what of roadmap. You've done a screen. Now, how did you help your patients feel about their results, or how did you help them think about their results? And so we're at a midline of 67%. Exciting. And we also want you to remember, and we will share the location for this in just after our presenters, that if you've entered more than 3 months, you can find your team's data on the participant page of the website. So as I said, we'll be reminding you of that link later in the webinar. Any other thoughts about data before we move to our presenters for the day? And Alana, I see your comment about the SBC rule. Yes, there is. It's primarily related to a chart when you have upper and lower control limits. Yeah, and that's why we tend to be
Oh,
cautious.
right. This is run chart. Yeah. No, I hear you.
Yeah. But that's great. It's great that it gives us a chance to talk about, oh, maybe someday we'll do this for a long period of time.
Are you asking teams to submit September? Like, how do we get you across the finish line is what's coming to mind. Like, how do we get teams to look backward into the summer and have more than 5 teams send in their data? I don't even know if we did, but I could rally the troops, right? And then, like how do you, like, because having run some of these national projects, you work so hard, you want to get it across so that you can declare shift or have that sort of sense of closure and having enough data to fully reflect on it. And that's what I'm thinking without saying it until now.
Alana, maybe what we'll do is there's one team who's been saving their data and has had just a real delay in DUA IRBs. And it's not someone from California, which used to be one of the harder states to, get all that in. So I think what we can do is, and maybe will draft something. I think having some notes from some of you can be helpful to say that. So I do think as we're getting some of this data, and I think we waited a bit over the summer. People are in and out, so we may be circling back to some of you just to put that rah-rah in for people, which would be great. And any other ideas welcome.
And also, I think it's also great learning that we may not have reached our goal, and yet we've learned a lot, and our data shows that I think sometimes people come into this work and think, oh, this is just a do it. Let's just ask the question. And our data shows that it really does take longer to accomplish the just do it of asking the question. And I think the stories we hear from you, Alana, and you, Maria, today will help us hear some of that. Carol.
I hit the wrong button. I was just going to put my thumbs up. I saw Sarah nodding, saying, yes, it does take longer than just any change in clinical process takes a while. So, yeah.
Mm-hmm. Okay, well, thank you all. Great discussion. Great thoughts about collecting more data. And we will move to the next slide because, as we said, we're going to spotlight some team presentations. And our first presenter on the next slide will be Maria Boucher. She is an assistant professor of pediatrics at the University of North Carolina Pediatric Sickle Cell Disease Program. Maria, please share with us.
Hi, everyone. Thank you for having me. Do I need to share my screen? Or
we'll move your slides.
Oh, perfect.
Just tell us. Yes.
Well, again, thank you for having me. And it has been a very busy summer for us. So I'm going to try summarize where we are in mental health screening and pediatric sickle cell disease here at UNC. Next slide, please. So I think the biggest change this summer is our wonderful fellow, who was a huge part of our QI project, has now graduated and moved on to big things. So she is now in Fargo, North Dakota, and she also had her first baby girl. In the midst of all this, she was very successful. She was able to present our QI at the National American Society of Hematology, Pediatric Hematology Oncology Conference in April in Seattle. And she also presented our QI, our institution evening of scholarship, winning the best QI award. Next slide, please. So what we have done so far, so I think we can pretty much say that we have incorporated emotional health assessment that's being done with each visit. And I think I could say pretty certain that at least twice a year, every child with sickle cell disease who is older than 14 years of age is getting screened with PHQ-9 and GAD7. And one of the changes that we have learned was trying to, how could we make it easier for our team to try to track down who has not had a screen done. So we were able to add the screening scores and the date within Epic on the schedule view. And I think what has helped our team the most is actually having weekly conversations about mental health as part of our kind of medical team discussion. So Monday mornings, we talk about everyone who was seen in our clinic and also looking forward who's coming in, and really just including these assessments as part of the sickle cell workup or maintenance for each visit. And we also develop a dot phrase to standardize amongst our team documentation of mental health assessments. and we have completed our resource list. Next slide, please. So this is what our run chat has looked since we started part of the roadmap collaborative. And I think we have sustained our goal of 80%, which is great. Next slide, please. So try to get some numbers just to get an idea of what the screenings look like. So we have had about 89 kids with sickle cell screened with PHQ-9 and GAD7. And looking at the scores, there have been a lot of variability, anything from 0 to 21, and for GAD7 between 0 and 16. And about 15 to 25% of kids do report symptoms of depression and anxiety above that clinical cutoff that we consider of 10. And about half of those actually have consistent mental health support. We are fortunate enough that we have a pediatric psychologist in our team who comes to our clinic once a week and also is part of kind of inpatient team. So she sees our children when they're in the hospital. So looking at her numbers, her referrals have increased about 40% since we started our screening process. So she has been very busy. And we can say that about 80% of the kids who are screened have connection with SAM, at least for more than 2 clinic visits or as a telehealth as well. And 20% only have had or established a visit with her only once. Next slide, please. So what we would like to do next is getting a little bit better idea of the referral patterns and what really looks pre and post the screening intervention, and also kind of understanding why some patients at certain visits will score really high and then the following visit the scores have changed a lot. Is it because they have mental health provider? Have they started medication? Is there a time point of the year, meaning, you know, they're not in school, it's summertime, and we just trying to understanding some of that variability. Also reviewing the barriers. I think we all know that there's a huge need for mental health support out in the community. The majority of our patients are Medicaid patients or patients with Medicaid. So there's a huge need for providers who can take Medicaid. So that is one of our or I'll probably say the biggest challenge that we have in supporting our patient population. And also clinically, you know, is there, I think the literature supports that about 30% of people living with sickle cell disease will have anxiety or depression. And I think in our small numbers, potentially we are around there. And is there a connection of mental health and increased acute care utilization, meaning that children with mental health come to the ER visit more often for, you know, sickle cell complications or not? And I think that's it.
Maria, thanks. That was really thoughtful and helpful, and I think many lessons learned. Lori, I was going to ask if you had any comments. Just some of the psychology, and Lori worked a lot at the Cincinnati Children's Sickle Cell Clinic as well. So Lori, any thoughts?
One is so exciting to see that the patients and families are actually getting this type of service. I'm calling it 5-star quality service by your team. So thank you for that. We know that when individuals have a chronic illness, that anxiety and depression often accompany that illness, and especially if the illness involves pain. So your numbers are expected, and it's just exciting to know that you might move forward. What we see, you know, we expect some variation in that depression and anxiety for some of the reasons that you that you mentioned. And, remember, those are only screeners. And so sometimes you get the variation because it's just a screen and you have a bad day or a good day, and your screen is different than how you might actually be feeling on a long-term basis. So just I applaud the work. It's so exciting.
Thank you.
Sarah, did you want to
And,
speak up?
Oh, yeah.
I was just gonna say I'm really impressed with the results that you've shared with us, but also the approach of like, okay, we're gonna do this and then we're gonna do this, and now what have we discovered? So I love hearing success stories. But really it's inspiring because it's like, okay, what could we also do here in Colorado to kind of keep moving ourselves along? So I just wanted to say, great job.
Thank you.
And Sarah, I totally support what you said. It was great. And Alana, we are working with someone who actually helped with the early design of Roadmap, has done quality improvement, and is now doing a lot of medical writing. She's a wonderful writer. And so you all may be hearing from us, because what we do want to do is Alana asked about some of the sub-analyses, and we're trying to look at things. What can we potentially publish? What are some stories to do? So stay tuned, and at the board, they're very, I did a preliminary presentation, and they really are saying this fits with the communication competency. And we talked with somebody from Children's Hospital Association today. So I think what we'll want to be doing is pulling on the work you all have done and these great stories. And so more to come as we start to synthesize some of this. So thank you for that. And I'm glad we're recording this, so it's really good. Back to you, Lucretia.
Yes. Any other questions or comments? Okay, we're going to move to the next slide, and you will see two photographs on this slide. These are the leaders for the Stanford Pediatric Cardiology Roadmap work. Megan Beatty was very involved. She's not here today, but Dr. Alana Kipps, who is a clinical professor at the Pediatric Cardiology Center at Stanford, will be presenting, and she's going to call out Megan's name in a minute. So Alana, if you could present for us.
Sure. Thanks for that introduction. Yes, very much on behalf of Megan, who is on a well-deserved vacation from all of us. And I hope she's having fun. She was sad to miss it. Next slide. I think you guys control the slides, yeah? Okay, good. I'm like, I don't have mine loaded. Okay. This will be a bit more meandering. Maria, thank you so much. That really was inspirational, because we're just on the cusp, like meet at 1 p.m. today to like try to figure out how to start to get at a more universal screening. So I'll get into that. But Roadmap has very much been embedded in a sort of larger project of mine, ours, very group oriented, to bolster the psychosocial support network and things that we can offer inpatients and outpatients for our heart patients out here at Stanford. Next slide. So this is a vision statement in progress. These are these can take a long time to write if you've ever had the pleasure. I remember being at the table when Cardiac Networks United was getting going, and half the afternoon was spent on this. So as it states now, we wanted to use holistic approach to emotional health support of patients and families impacted by heart disease by supporting families across every stage of the cardiac care journey. We aim to nurture hope, resilience, and overall well-being, and really pulling from a large group of different ancillary services and experts to do so. Next slide. I have taken, and we have taken inspiration from a number of places, including all of these roadmap webinars, the Thrive program out in Kansas City, and who were generous enough to let us borrow their name in QI spirit, the MCOPE Center, the Cincinnati Center, all of these embedded amazing programs that serve pediatric heart patients and their families already. And then PAC3, which is an acute care cardiology collaborative that I founded about a decade ago. The Patient and Family Action Committee has really kept us on our toes and thinking about this when we design our various conferences. So I definitely come inspired by them and my own patients in clinic. And then we have a new palliative care, like bigger service called Koala, which is adorable, and they have koala bears all over the place, which is quality of life across the ages. And so they inspired me too. So next slide. A few years ago, I think 3 years ago, we were still in the middle of the pandemic and not knowing if we could take off masks and meet with Ollie Hinkle Heart Foundation, but we were given this like absolute too good to be true, but it was true gift to partner with this foundation, which was founded by a bereaved heart family out in St. Louis. And this really allowed us for the very first time, apart from our inpatient social work team who did a lot of this work, to offer therapy to more than our like heart transplant patients, which have to have a link to our psychologist in order to weather that journey. I, as a general pediatric cardiologist in acute care or in my own clinic, really didn't have a way to link patients with help sort of directly. Obviously, they could get a referral from their own pediatrician, but there was no mechanism. And before Roadmap, there really wasn't a mechanism even to properly, consistently ask about their emotional health. And so that is definitely what we have gained, and then some from this partnership with you all. Next slide. So this is the list of hospitals that thus far have had the benefit of partnering with the Ollie Hinkle Foundation. Next. So us, by promoting it, et cetera, have reached 150 parents, siblings, patients directly, for some almost 1,000 different sessions. They seem happy with it. We're figuring out a path forward to continue this partnership after our current contract ends. But it has been really, I think, a spark to allow us to discuss emotional health by being able to do that, like, don't just scream, but have something to offer. So I'll show you in a moment, we embedded this way of documenting Megan and I's conversation with families over the year that we've been doing this. And one of the drop-down menus is to put that link to Ollie Hinkle so that families can find that in their MyChart or printed letter home after clinic visits to be able to refer back to it. And I often phrase it as, this may not resonate today, but it may be for our next visit. And, especially kids who are about to enter adolescence, or, times when this may bubble up more to the surface, and know that it's always there, that you can find it and lean into it. And that I never know if they decide to do so. Next slide. So it was sort of inspired by, some of us got together in order to just bring Ollie Hinkle to Packard. And then we'd been doing that for about a year, and I was like, why don't we get back together? I knew some other people, out of Cincy and Michigan and whatnot. And so we built this Thrive team, and I just wanted to outline that Megan Beatty was very much the site leader for Roadmap here, and is our ongoing fantastic collaborator because she does fetal, which I do not anymore, and more outpatient. And so she has been delightful. And then you can see sort of the rest of the types of multidisciplinary folks I've recruited. And they've been very, very invested and donated a ton of time. Next. I was happy that Maria was able to share some of the data from the last many months. I don't have outpatient data yet because we have no screening mechanism that uses, the verified, validated questionnaires like her team is using, but we did use those types of questionnaires. I don't think they're listed here specifically, but to the subset of families in the CVICU who you're there for at least 10 days. So it is sort of perhaps a higher risk, higher acuity set of all the umbrella of heart patients, but quite a bit of, and very similar to what's in the literature, our patients are experiencing, and parents, this is mostly parents because they're little kids, but 50% moderate anxiety, moderate depression, and those stayed true, only attenuating a little bit at the 1 and 3 month follow-up. And then I believe Magna's collecting data at like a year out. Next slide. But this also inspires us. We know that not only in the literature, but our own backyard, our families are really experiencing this level of need. So we basically spent a year as a Thrive team documenting our current state and documenting the gold standard and what the AHA says we should all be doing. And I made a pitch and somehow that landed, and I was, not me, but like it was agreed upon that 2 full-time clinical educator, faculty, psychologists could be hired. We recruited, we got people to sign on, and they have now started, which is a source of joy for me. So one literally a week and a day ago. So we are still in the building phase. Now that there are boots on the ground, we can really get going. So this is where we're going to focus and try to like maintain some semblance of scope so we don't overpromise and underdeliver. But we know that our true north and our need will be beyond, fetal pulmonary hypertension and the general cardiology sort of well-off patients. So next slide. I promise I'm getting to the roadmap in just a moment. You can cut me off anytime. We can bypass this. This is some other like offshoots of Thrive that our social work amazing people have put together, including a parent groups and stuff. Let's skip this one. I put it under the umbrella of all this, but we can skip this one and the next one, an offshoot of PAC3 and the Patient and Family Advocacy Committee. These are all posted in our acute care areas. So grounding us back into the roadmap, which is today's webinar, we used all of the wonderful slides that you gave us. We borrowed heavily from like Nationwide and their slide deck when we wanted to start really socializing this beyond the borders of Dr. Beatty and my own clinic populations. Next slide. As I promised earlier, one of the things we did just to keep Megan and I honest and documenting when we did, have these 1 to 2 minute chats with family, trying to use Dr. Sood's technique, is I asked people to build out .cv roadmap, a dot phrase, which brings up this drop-down menu that, as you can read faster than I can, but like we can check the boxes. And so usually I'll check at least education or, and I always check Ollie Hinkle, because that brings up this other blurb, which I don't know if it's on here. Yeah, it brings up this blurb, which is what they wanted us to say, and the website so the families could find it. Again, they may not feel like they want to lean into it then, but they know where to find it. Next. So we used that and made sure that it was working. This is the run chart that you all were nice enough to put together into the newsletter about a month ago from our site, just the cardiology aspect of Packard, and we got to 100% the last couple of months and did fairly well really as of late last year. Again, just me and Megan reflected in this. Thank you, Carol. Which we did try to go back and audit, and like, even if I remember talking about it, but I didn't use .cv roadmap in my note, I didn't give myself full credit. So anyway, this is the 2-person version of the run chart. Next. And you'll have to let me know if we're delinquent on the summer stuff, because I will go back and do that for y'all. So the local spread effort to date. So reaching across the aisle to at least the rest of the general cardiology clinic physicians at Packard. So in December and January, we held hour-long Zoom meetings each with about 5 participants from that. Basically, there's only like 10 more people who do that. There's a lot of subspecialty silos at Packard. We didn't try to reach the PH team yet, but so there's 10 people. So between those 2 webinars, we reached most of them. And if they couldn't make one of those, Megan like met one-on-one. They're often echo docs, and so she's literally reading next to them so she can make the pitch in person. And we definitely got the support and sponsorship of the section chairs about patient cardiology, Raj and Hun and Deb Ho, and then our division chair, Ian Dubin. We presented the full roadmap over the course of like a 15 minutes on the agenda to the 70 plus members of the pediatric cardiology faculty in June 2024 to just get it in front of people and inspire them. We didn't give them like the whole nitty gritty. Like I don't expect someone to just listen to that who's not in the general cardiology faculty and just start using it tomorrow, but baby steps. And then we realized in putting these slide decks together that the .cv roadmap epic report, which I had hoped would be a source of truth of like whether people are holding these conversations, it's pretty flawed right now because it captures like the fellow or the resident who started the note and not the actual attending of record. So we'll get there. So I sent a quick survey literally Friday night, and Monday I texted everybody the link. So I did get 9 out of 10 to respond, and we'll look at that now. Just a pulse check of like whether they're doing this. So this was the Qualtrics survey that I threw together. It's like, are you asking them? And we define that the kids that we're seeing at least as frequently as like every 1 to 2 years, like the kid who presents with a murmur who's being discharged that same day with good news, like we're not like scrutinizing. Are you using the dot phrase? What barriers are you facing? Next, we will share the data from these 9 people. And I did not contaminate this with my own responses. And I don't think that Megan did either. This is really the spread cohort folks. So you can see in this, I don't know, I should have made these more discrete teal. So the teal and the green is quite a lot of asking, using the Dr. Sood method, et cetera, their iteration of it. But still a ways to go in terms of bringing it at or above 50% for the most of these 9 folks. Next. Most are not using the .cv roadmap in their notes, and that's okay. So that helped explain why one of the reasons that there didn't seem to be enough line items in that epic report. Next. We asked, are they promoting Ollie Hinkle? So this has been one of those things that's been around now for like 3 years. They're more used to the fact that this is in, and so we have some flyers available in our clinic, et cetera. So this has more of a time horizon, and most strongly agreed that they promote this fairly frequently. Next. And then the barriers, right? Like the important thing to like drive up improvement within this 9 and to foresee the barriers for like the next 2 PH gurus that I would like to spread this to. So, time constraints was listed by 6 out of 9. Fear of uncovering major emotional needs, not knowing what to do with that information, 2 out of 9. And 8, they could select more than 1, by the way. And 8 meant to, but forgot. So, I mean, I definitely fall into that trap now. I do have to say in the sustain phase that now that I don't have to turn data into Megan every single month, I've reflected on my own clinics and go, oh, I didn't quite get there. So it will be, I'll just have to keep that in mind. Next. So these are the people we've recruited. Dr. Harley, who started last week, Dr. Liz Loy, who's ended her postdoc and is early faculty and is coming over from the NICU, but experienced in the Heart Center already. And then we have a mental health clinician. So I think that these people being around and available, and we can literally start making referrals, like I made one yesterday, will hopefully get to what Maria was just describing in terms of like, I expect if we could do this right, they will get busy fast and have roadmap be a link to the ability or the mechanism for referrals on top of a screening mechanism that I hope to build out with their help. Next, I think we're close to. Yeah, next step, I just enumerating sort of how to link roadmap and roadmap sustain phase for Megan and I, and ongoing spread efforts to the, the true north of the bigger entity of Thrive. I'd like to loop back with all this now that we have that survey data that I haven't shared with them yet. Subset of fetal cardiology, since that's a major focus for Thrive, we should make sure that they are intentionally asking, which I think they already do because it's such a part of fetal counseling, but perhaps have them develop their own type of dot phrase and certainly a mechanism for referral. The PH team needs to be fully looped in, including their advanced practice providers, and then just figure it out. So, and I don't know if I can improve the .CV roadmap to be a source of truth, because I don't think that it's reasonable to ask people to look back every month to their own, clinic notes to be like, did I do this? Did I not do this? But if you don't have data to show them, it can fall apart fast. So next, I think that's that. Yes, questions, comments, advice, open ears.
Alana, that's great. What an amazing on many levels that you've done there. And I love this logo. That's great with the Stanford tree and that. One thought as you bring on the psychologists, and I'd ask Lori and Sarah to comment on this. One of the teams that was in the pilot of Roadmap a few years ago from NYU, Becky Lois did a really nice job of being at the division meetings. And I'm going to get more specifics from her, but I think part of what she did was ask people what some of the barriers were. She'd help talk with them about it. So she started to have, I think, some mini office hours to be available. And so it was really, she wasn't just a referral, handoff. It felt like what I remember her talking about was how she tried to help the clinicians in what Erica said, start those conversations and feel more comfortable about it. So, and I don't know, Sarah or Lori, you weren't in our pilot work, but I suspect you've done some of that. And Sarah, maybe you would have as well. So, but again, great work, Alana. Yeah.
Thanks.
Yeah, I agree. And I think it is, it's definitely, it takes time for the team and for everyone to sort of adjust to that even being an option or being offered or being part of the visit. And so it's I think we're happy, I'm happy, I'm sure Sarah's too, they're happy to talk offline with the new psychologists if they would like to. So, we're happy to give some tips or lessons learned. I don't know, Sarah, if you want to add anything else specific.
Yeah, I will say I was really excited to hear that you have Ollie's branch there as well, because I know here, at least in Colorado Springs at the hospital, there was almost like a collective sigh of relief, like, oh, good, we have a place that's dedicated for our patients, and we have some wonderful providers in the community. So that's really exciting that is part of the pathway of let's get them connected. But I agree with Lori that it just takes time, and we're comfortable having these conversations all day long, every day. But to do that with our medical team members, it's exciting to me when people start getting more comfortable having conversations about mental health, and then really thinking about it, whether we're in the clinic with them that day or not, to be like, oh yeah, I used this and it was really effective and so simple, and I wasn't scared, that I knew what to do. So it's exciting to hear about your work, and I'm inspired. I'm like, oh, that's a great idea to do a mini survey, just keeps it on everybody's kind of dashboard of oh yeah, let's do this. So I might steal that idea.
Of course.
Yeah. And Alana, I was wondering, is there a way, even at the division meetings, that, the division chief could maybe pull some of that data, and it could be just about using some of those, the questions you have in the dot phrase? I'm just wondering, and maybe you could show how you changed over time, or, you talked about in PAC 3, some of that, it's collaboration, competition where people, but I'm wondering if the division chief could say this is important. It'd be anonymous, potentially, but some way to
Yeah,
sort of.
we ran it
to-
via,
Yeah.
it was anonymous, like that data that I don't know who,
Yeah.
filled out what, right?
Yeah,
By the way, I emailed, of course, it literally was email on Friday night because I forgot to send it earlier
Yeah,
last week
yeah.
and I needed to turn in my slides
Yeah.
Monday, right? So did I text it by texting? Way better. I know everyone has a different culture, but like if you want people to
Yep,
fill
yep,
something
no.
out, say my slides are due tomorrow. And
Yeah, exactly.
all of a sudden
Yep.
I got done. It's done. I mean, it literally took them like less than 2 minutes. So,
Yeah.
for what it's worth.
Yeah.
Yeah. Yeah, I think one of the barriers locally is unlike just about any other part of cardiology, there is no subsection that meets for general cardiology. So it is a bit of, whereas like the PH team meets, the PAC team meets, like the echo team meets, the field, and like, oh, there's all these, like everything under the sun has a meeting.
That is a good point. Yep. Yep.
And so I does need to be sort of at that 70 plus member division meeting, but then the rest of the people who only work in the CVICU are sort of, so I think, I'll probably need to embed it in like routine quarterly, like Thrive updates, because that touches hopefully lots of parts of the heart center, and then maybe do these pulse checks. I don't know, at least twice a year, if not, 3 or 4 times a year, because it basically is a little bit of a kind nudge, right? Of like, doing it, asking, and then just add more people to the texting train, like once we loop in like pulmonary hypertension or whatever.
Yeah. I also think, I wonder if, as Maria talked about, and she had a smaller group there, and it focused on sickle cell, but is there a way that I'm trying to think of having beyond the cardiologist, whether it's a psychologist or the nursing staff, social work, if there's some weekly huddles about the patients coming in, that emotional health gets highlighted as, here's what we want to make sure we check on. I don't know. I'm trying to think about, it is hard when you've got a diverse and diffuse group, but trying to think about how that might work.
Yeah. Well, I think we have a path forward to discuss and integrate to pre-existing multidisciplinary meetings about the inpatients, but the outpatients is a bit of a crazy, because they're like, all of it. I have 3 half days a month. Like everyone has this a ditzel of clinic. And so you're not, I think that's why it's harder for people to lean in when it's not a huge part of their like clinical footprint. But it's all right,
Yeah, can get there.
Great discussion. And while people are talking,
Lucretia, I just wondered, we've got Casey and Michelle who are here as well. And I wondered if they wanted to just say anything, ask questions, or just say what's happening where they are. Sorry to call you out, but
Yeah, that's actually our next slide. It gives everybody an opportunity to just speak up and share what they're thinking, what they've been doing. And it's also okay if you don't want to speak up today. So
can I ask for the people who were in the earlier cohorts, has anyone sort of cracked the code on ongoing internal collection of data? I mean, given that my .cv roadmap epic report's not clearly a path to doing that for us, and given my own observations of my own behavior, who's hyper invested in this work, slipping a bit from our 100% days, like as what teams, like, I don't know, is that, I feel like that's maybe been discussed, but I can't remember what it was.
What I'll say is, I think, and in the pilot, it launched mid to late January 2020. So you can imagine it, people were getting their DUAs and IRBs and they basically paused. It was an incredible group of 16 teams. Data, people did try to collect data. What I'll tell you is that, and we're following up with NYU, their diabetes clinic was the one that launched it. And the person who was leading that work became the head of the outpatient subspecialty clinics. And they were going to spread it to 2 more. So, and Ron Lee, who is now in Colorado, was the head of that NYU team. So I think, so we are following up with them to get sort of where they are. They started to spread to 2 very different types of clinics and to see how it worked. So we can ask them about data. Yeah, and that's right. Atrium was really doing a lot, I think, with the Epic, right? Lucretia and their template. So we can follow up with them as well. They have someone that I used to work with who's now there, who's developed this whole quality program. And so the data is really a part of what they're focusing on and doing. And Alana, what we've got several articles that from recently that have just been accepted for publication. One about the MOC document. One is being published that we did in partnership with NASM and will be in pediatrics. So part of where we are is we think we've got what works well. And so how do we spread this and share it with other organizations that can take it on? Some of the networks are interested in this. We've got interest from Sam Henkes, a cardiologist at Cincinnati, who's now leading the Pediatric Experience Collaborative. A lot of parents in that are very interested. It's a 21 hospital consortium. So we didn't know if it made sense for us to do another cohort, but rather to start to work in a way that could help embed we're refining the tools so it can be easier. But as you know, Lucretia said, as you all noted, it's not something you just can hand off to people. You have to help them know how to do that. Yeah. Chanel, maybe you can make a link and I can send you he's the patient experience lead now at Cincinnati. And so there's a 21 member consortium. He has said they are very new. They're not quite ready for QI, but he wants us to start with education. He thought it would be too overwhelming for them. So, yeah. And Lucretia, Lori, any other comments on that and sort of next steps?
No comments
So
on
if I'm
that.
hearing,
Oh, go ahead.
go
Go
ahead.
ahead, Alana.
What I'm hearing, Carol, is that like at this phase, if I can draw analogies to, PAC3 and our like chest tube work, you've done the pilot, you've done the pioneer centers, you've done the spread cohort, which is like us, right? And more data collection. And now we sort of have the building blocks for a change package that doesn't need quite as much hand-holding by you all in webinars, and then this content will be accessible.
Yeah, we would like that to be true. I think what's hard is it often, I think if we can package this and we're updating some of the videos, trying to make it really simple, and how could we guide someone to implement where they are, and I think as you all have learned, you start doing this, and I think both Maria and Alana really highlighted this, that you start doing it and then you uncover more and more things that you want to look at or connect to or do. But it's a start, and it's making, you both have done great. Sarah, we know that what's going on at Colorado is great. You were highlighted in our, newsletter this month. So really, really exciting how that's doing. And I try to remember that in improvement, you start, and just it's multiple steps to get to that. So, but Lucretia, I'll hand back to you. I could keep going on about that, but
Yeah, we are very excited about what the next phase of spread will look like. And as Carol's been saying, we've taken all these great things that we've learned from you and are adapting a lot of our resources and, of course, our change package. So coming soon. In fact, the revised readiness checklist is already on the website. The elevator speech is very, very close. That generic introductory PowerPoint is actually based on the nationwide PowerPoint that Alana was talking about earlier. It's also very close, and the change package is not as close because there's so many resources that you've helped us improve. So be on the lookout for those things. We'll let people know as things are updated in the newsletter. Chanel, do you want to say anything about the website?
Sure.
Or Alani? Yeah.
Yes, we've made a few different updates to our website. Our wonderful communication consultant, Alani Wilson, has gone in and done some rearranging. So we just wanted to highlight really quickly that we've moved where you can to get to the participant page on the website. So if you visit our website, it's going to be underneath the About tab at the very top. And then let's go to Roadmap Initiatives. And then if you scroll down, you'll find this little cute graphic where it has the Roadmap Collaborative, and that's where you'll find the participant page. So that's where your run charts will be, your readiness checklist charts will be, your bar charts will be, and then all of the recordings and resources and links that we kind of shared throughout the collaborative as well. We don't have any idea of closing this anytime soon, but we will definitely keep you guys aware if we eventually move this to a different page. But right now, this is going to definitely be where everything will rely on for there. Next, we do have our MOC Part 4 information. I didn't know if Lucretia, you wanted to share this or if you wanted me to.
You can share it. And honestly, this is where we're getting most of our questions right now. So as we're moving toward we are at the top of the hour. Please feel free to ask us questions as we're beginning to wind down. And Chanel, if you just want to quickly hit the high points here.
Yes, of course. So just like we've stated on this slide, throughout the collaborative, 6 months data, continuous data collected as well. There is an attestation form that you do have to submit. It is through CCHMC, so it's not through the ABP portal. MOC Part 2 is through the portal, but that is outside the collaborative. The MOC Part 4 is only specifically for the collaborative teams and for you guys. So we have emailed that attestation form, but if you need at any time, just email the ABP Foundation email and we'll send it back to you. Once we receive those, we'll get them signed and then sent off to ABP, and then you'll get an email confirmation that it has been added to your account within about 2 weeks. And we do submit those forms on a weekly basis. So just FYI, if you do send it to us on Monday, we typically send it out on Friday. So it might be that a little bit of a 3-week delay, just depending on that. So we send ABP an email weekly of those forms. So just an FYI. Any questions on that before we end for the day?
I don't have a question on this. I just wanted to say, this has been a great call, much smaller than our usual calls. And I think and I think our team will talk about, are things like this helpful? Alana, Sarah, Maria, every 4 months, every 6 months, just to sort of check in and see where people are. we're just not sure. Oh, Maria, yeah, if you want to put in, is that Chanel? If you can see Maria's comment there. So just thinking as we go forward and are sort of synthesizing things, are there things that, how do we keep in touch? What's a good way to just keep connected, I guess, is part of the question.
Yeah, and you can,
maybe it's
Maria, you can reach out to the ABP FDN project or to Chanel and I, or copy all three emails and make sure we're all working that day.
Thank you.
Oh, Michelle, thank you.
I would be in favor, a couple of times a year getting back together. At least even if it ends up being a small group like we are today, keeps it in mind. Again, I almost wonder if people would be receptive to every 6 months, like a week or two before that, like reflect on the last month. Do you think that you are still doing this? Like at least, here, like, did you Kips do this? Did you Megan do this? Maybe that will prompt them or us to reach out to our sort of spread local folks that didn't go to the webinars. I don't know, like a couple times a year, I don't feel like there would be any harm to that. And if it ends up being an intimate group of people who can, talk about, whatever, everyone takes this in such many different directions, which is cool. It's always how we approached, like the chest tube stuff. It wasn't like, this is the bundle, follow it or don't, like, it's like, you do you, try to lower
Exactly.
it. And so this is sort of similar.
Yes.
It's like carve your own path, but our true north is similar. So
yeah. No, so true. So let's so maybe in spring we can be if 6 months we're thinking of that, we can be thinking of something and maybe bringing in people like NYU or some of the others. Our hope was that in this collaborative, getting some people from different divisions within the same institution to work together would help keep things rolling. And I think that's what NYU, Atrium, and Colorado certainly have been doing. So yeah.
Sarah, you
Well,
might be up in
thanks.
6 months
Oh.
to describe what you've done.
Yeah, that's right. That's right. That's right. And Michelle, did Michelle drop off? She might have there. Yeah. Okay. Okay.
Thank you all.
Thanks so much. Yeah, great to
Thank
hear from
you.
you. Thanks for all the good work that's going on. It's really wonderful. So thank you.
Bye.
thanks, guys.
Bye, everyone.
Great.